Hello everybody, welcome to our November workshop video presented by Kyle and Todd. And in our video we're going to be talking about collateral ligaments in the knee. Okay, so just a little refresher on anatomy of the knee. You have two collateral ligaments, one being the medial collateral ligament and the lateral collateral ligament. The medial collateral ligament is thought of just as a thickening of the capsule of the knee capsule, and it runs from the lateral or the medial epicondyle to just below the pes anserine, and it is thought to have a superficial portion and a deep portion. And then the lateral collateral ligament runs from the lateral epicondyle down to the fibular head. So the first thing we're going to talk about is the MCL. Um, the MCL is much more commonly injured than the LCL in sports. It's very common in football and ice hockey as well as other contact sports, and it's also pretty prevalent in skiing. A typical mechanism is a planted foot and then receiving a blow, valgus force, to the outside of the knee, pushing the knee inward. Okay, so the MCL's role in the knee, obviously it's to resist valgus forces. At 25 degrees of knee flexion, the MCL resists about 78% of valgus forces, and then at full extension, it resists about 57% of valgus forces, which is still a pretty large chunk. So it's pretty clear that it's a main stabilizer against valgus forces. Alright, so indications of MCL sprain. What you want to look for, first of all, location of the pain and swelling. MCL swelling and pain is typically localized at the insertion of the MCL on the femur or posterior proximal region of the joint. This is about 65 to 75% accurate. Next, you want to obviously ask if they had a sensation of a pop or tear, or if they heard anything. You want to palpate for deformity, see if you can feel anything missing there. And there will be a fairly quick onset of swelling and muscle guarding. Okay, so special testing for MCL sprains. Obviously, we are going to look at the valgus stress test. It has a pretty good sensitivity of between 68 and 96% according to two separate studies, with the specificity not reported. Laxity grades, normal is 1 to 2 millimeters, mild 3 to 5 millimeters, moderate 5 to 10 millimeters, and severe is more than 10 millimeters of laxity. It has an inter-examiner reliability of 68% in extension and 56% in 30 degrees of flexion. Alright, performing the valgus stress test, you want your patient obviously in a supine position. You're going to lift the injured leg off the table with one arm, usually grasping just above the ankle. Then you provide a valgus force by pushing on the lateral aspect of the knee with your other arm. The test should be performed twice, one with the knee extended and one with the knee at 30 degrees of flexion. And it is very important to make sure that you do the test on both limbs, the injured and uninjured, so you have something to compare it to. Okay, so interpreting valgus stress test. First, you want to look at the position when you do the test. So if you have excessive gapping and pain with the knee extended, it's typically the deep and posterior fibers of the MCL that are affected. There's usually ACL, PCL, or oblique ligament involvement 80% of the time that there's an MCL injury. It's coupled with another ligament, and 95% of the time the other ligament is the ACL. Gapping and pain with knee flexed in 30 degrees is more of the anterior and superficial fibers of the MCL that are involved with the injury. Okay, so moving on to the lateral collateral ligament. It is the least common knee injury. It usually occurs with a more complex injury, such as a fibular head fracture. It doesn't happen very often, but the LCL's role is to resist various forces at 0 to 30 degrees of knee flexion, and it also limits external rotation. Signs and symptoms of LCL injury include varus trauma, or impact to the medial aspect of the knee, pushing the knee outwards, swelling over the lateral collateral ligament, painful palpation over the LCL, also increased joint separation, or a positive varus stress test. Okay, so performing the varus stress test, the patient is supine on the table. The AT lifts the injured leg off the table with one hand, again typically holding just above the ankle. The other hand places a varus force through the medial aspect of the knee. The test is performed twice in full knee extension and 30 degrees of flexion. It's also important to compare to the uninjured limb. Finding sensitivity and specificity on the varus stress test was very difficult. There's not much research done, and it was hard to find the little research that there was, but it did report a sensitivity of 25%, and the specificity was not reported. Alright everybody, thank you for watching. I hope we refreshed your memory a little bit, and have a great Thanksgiving.